So this is Dr. Cripps, one of the doctors in Manchester, who's going to take you through a Pyrexial patient. Over to you, Nicole.
Hi everyone. So today I'm going to be talking about a Pyrexial patient. So we'll start off just with the case. So you're part of the medical team and you're admitting this patient who's been seen by A&E. He's a 43-year-old man. He's attended A&E and he's just been feeling kind of generally unwell for the past 2 months. So he's been having kind of muscle aches, night sweats, he's lost his appetite, and he's just been feeling a bit short of breath. But when you do your kind of systemic review, there's nothing really obvious about where this is coming from. He's not had any headaches, chest pain, palpitations, abdominal pain, change of bowel habit, or urinary symptoms. So when you kind of continue to take your history, you find out he's had a previous femoral pseudoaneurysm in 2018. He's not on any medications. His dad died of bowel cancer when he was very young. He doesn't have any allergies. And when you ask about his social history, he's an IV drug user. He smokes about 20 cigarettes a day and drinks between 5 to 10 cans of beer a day. So you just check his observations before you go in. And you see that he's got a temperature, so it's 38.1. His heart rate is 103, so he's a bit tachycardic. His rest rate is normal at 17, and blood pressure is 134 over 87, and SATs are fine. So in terms of your differentials, obviously this is quite a non-specific presentation. So you probably have quite a broad set of differentials. You'd probably be thinking about whether he might have some sort of ongoing infection, whether it could be something like cancer because he's having these night sweats, something hematological. You might think about something to do with his liver, potentially hepatitis or something like that, especially with his history of IV drug use and the kind of long ongoing symptoms. So there's lots of different things that you'd probably be considering. So you want to go and see them, examine them, and start to narrow it down.
Nicole?
Yeah?
So can I just ask a question? So did he have any you mentioned there's no change in bowel habit or anything like that, but did he have any weight loss?
No.
Okay, because you could think with night sweats and things like that, you could think of lymphoma. That would be another differential.
Yeah. So you go in to examine him, and on examination you do your A to E. His airway's patent. When you listen to his chest, it's clear. And when you examine his circulation, his pulse feels strong. His capillary refill time is less than 2 seconds. But when you listen to his heart sounds, you can hear an early diastolic murmur, and it's heard loudest at the left sternal edge. So this would be an sign of an aortic regurgitation murmur. And when you examine for disability, he's alert, his GCS is 50, and he's got a temperature. And then everything else, his abdomen soft non-tender and his calves are soft non-tender. So then you have a look at his hands, and you notice that he's got these kind of small red dots over the palms of his hands. And when you ask about them, he says he's kind of noticed them for a while. He can't really remember when they came on, but there's definitely become more of them. So thinking about your initial investigations, so you'd heard this murmur, so you definitely want to have a look at his heart. So you'd want to get an ECG and potentially an echo to have a look at why that murmur's happening. You'd probably want to get some baseline bloods, see if there's any infection going on, get Usenease, check his kidney function. If you're thinking about hepatitis, you want to get some LFTs and CRP to see if there's any inflammation going on. And you'd also want to get a chest x-ray. If you're considering lymphoma, you might see something on there. And he's also mildly short of breath, so you'd want to see if there's any signs of, anything going on in the lungs. And then you could do urinalysis as well, just to see if there's any infection going on there. So kind of a full septic screen to see if there's an infection. It does have a temperature. And you'd also want to do some blood cultures as well to see if he's got any bacteremia. So this is his ECG. And so if you just kind of have a look through it, you can see that the rate is regular. He's not tachycardic. Sorry, the rhythm's regular. You can see there's P waves present. The QRS is narrow, and there's no ST elevation throughout all the leads, and the T waves look normal as well. So this is a normal ECG. And you look at his chest X-ray, and when you do your kind of A to E analysis of that, the airway is very central, the lungs are clear, no signs of infection, the heart is a normal size, and the diaphragms look normal, and you can't see any bony issues. And his urinalysis is normal as well. And so you get his bloods back, and you can see he's kind of mildly anemic. His white cell count is raised, and so his neutrophils, which makes you start to think there might be a bacterial infection going on. His useneas have come back as normal. His LFTs are normal as well. And his CRP is raised at 73. And blood cultures, you don't usually get back for a few days, but we'll say that you get them back straight away, and he's got Staph aureus in his blood. So you've also got your echo that you ordered. And when you get the report back, it tells you that they can see some vegetations on his aortic valve, which is, you can see on the right there. And this is just another example of an echo with vegetation with the mitral valve vegetation. So having seen all those investigation results and heard all about his case, your top differential now, I would hope you'd be thinking about infective endocarditis. So that's what we're going to be talking about today. And I'll tell you a bit more about why those investigations have confirmed that for us. So just a summary about what infective endocarditis is. I always was a bit confused about what it actually was. So it's basically an infection involving the endocardial surface of the heart, which is kind of the superficial layer that covers all the inside of the ventricles and the atria and the valves as well. And what happens in infective endocarditis is bacteria kind of pass by the heart valve, and they attach themselves onto the surface of the endocardium. And then over time, kind of clumps of cells and bacteria form a little clump on the endocardium, and these are called vegetations. And if these are left untreated, the vegetations can cause damage to the heart valves, which is why patients often get a new murmur, and can also lead to heart failure and life-threatening embolic complications. So little bits break off of the vegetations and kind of lodge elsewhere and cause issues. And it can also lead to death as well. So it's quite a serious diagnosis. So obviously a lot of people get bacteremia when they're kind of septic and things like that. So why do some people get infective endocarditis and why do some people not? And basically there's a lot of risk factors that can put you more at risk of getting it. So kind of divided them into two here. So one of them is damage to the heart valve. So if the heart valves are damaged, it's much more easy for bacteria to kind of lodge themselves into the damaged area. So people with artificial prosthetic heart valves are more at risk because there might be just some damage around the area. And also when they get put in, there could be bacteria that just somehow get in. Patients with congenital heart disease, they require sometimes prosthetic valves, which puts them at risk. So if it goes, things are unrepaired, there might be damage that happens to the heart, which causes bacteria to lodge in. People with acquired degenerative valve disease, because there'll be damage going on around there. People with hypertrophic cardiomyopathy, because again, there can be damage to the endocardium. And people with a previous history of infective endocarditis are more, I think, are more likely to get it again. And then another kind of side of the risk factors is actually the more bacteria is introduced into a bloodstream, the more likely it is that it's lodge itself in your heart. So when you get a cardiac implanted device put in, obviously that's quite near your heart. And so if any bacteria get in, then you're more at risk. And people who use IV drugs, like the patient we saw, obviously they're putting needles in that may not be clean quite often. So you're more likely to get bacteria in your blood. People who have had recent dental work, it's quite hard to kind of keep the mouth sterile. So it'll be much easier for bacteria to get in. And, you know, like post-op wounds, anything really that kind of opens up the skin and makes it easy for bacteria to get in and into the bloodstream. So the symptoms are kind of quite non-specific, really. Kind of the common one is an ongoing low-grade fever. Patients might also present with shortness of breath. Some of them might present with some heart failure symptoms. And they also might have kind of muscle aches, joint aches. They might have a headache, and that might be just kind of part of the whole systemic issue, or it could be that they've actually got an embolus that's gone into their brain. And they might also have night sweats kind of as a result of the infection. But I'd say the main thing that I've seen anyway is it's patients who've spiked a temperature, really. And often you'll see patients on the ward who, if they grow Staph aureus in their blood, which is a bacteria that commonly causes infective endocarditis, microbiology always asks you to do kind of 3 blood cultures and an echo just to make sure. So that could be a way that people get diagnosed as well. And so people can present in kind of an acute way, which is where the symptoms develop over like days and weeks. And they're like spiking lots of temperatures, tachycardic, and feel really tired. But then also people can present subacutely, so kind of just grumbling on for a while. They have very vague symptoms, so they're not necessarily going to present very early, and it develops over, say, months.
Nicole, sorry
yeah,
to interrupt. Do you mind just going back a couple of slides just to the risk factors? Because I think it's a really important point that you make, that, you know, these patients can be quite difficult to pick up and diagnose, and you have to have a real kind of high index of suspicion. And so these predisposing factors are important to kind of bear in mind. And I think when you're taking the history, these are things you're going to actually actively look for, and kind of, you know, and particularly on the right hand side there where you've got introducing bacteria. So yeah, absolutely, bacteremia. I think when we take histories, we often forget about asking them about anything that may have introduced bacteria. So it's important. I think it's important to have to in your history taken to think about that. Think whether they've had anything recent, done any dental work, and then also when you're assessing patients, to look at other parts of their body as well. So often we find patients may have discitis or something like that, which is kind of a chronic infection, or discitis, and then that can lead to endocarditis as well. So that's all. I just wanted to make that point.
Can I just ask a quick question as well? Sorry. When you have say a pacemaker when a patient with infective endocarditis, is that ever an indication to take the pacemaker out if that's, you know, causing the infection, or does it get a bit more complicated than that?
Yeah, so absolutely, that's in fact a very strong indication to remove the pacemaker and any device, and it's a complete extraction. So it's really, you have to be really careful with pacemakers devices. If they develop endocarditis, which can, the vegetation can actually go on the lead or the leads within the heart, and that sometimes that, you know, you have to just remove the whole thing really. But yeah, that's a very important thing about pacemaker endocarditis. The other thing I was going to say, so pacemakers is the other thing. The other one are indwelling catheters. So the other culprits are the patients who are on, say for example, you know, long-term chemotherapy, and they've got Hickman lines, or patients who've got on hemodialysis, which is done through a line rather than through a fistula. So they're at higher risk of developing endocarditis.
So I've just got some signs here. So the one on the left these are known as Janeway's lesions. So they tend to be kind of non-tender hemorrhagic lesions, so kind of red erythematous almost, on the palms of the hands and the soles of the feet. And then you've got Osler's nodes, which it's quite easy to get confused between the two, I think. But Osler's nodes are like tender lumps, so they're raised. They're kind of a red-purple color, and they can sometimes have a pale center, and they're kind of more on fingers and toes rather than like on the palms of your hands. And then you can also get Roth spots, which are like little hemorrhages on your retina. And these can be caused by like little emboli that break off. And they have a pale center, and they're quite a rare finding. So the signs can be kind of divided into three as well. So you've got your cardiac signs, so the new murmur, and you can also get immune complexes. So when the septic emboli break off, they can cause kind of inflammation and release of immune complexes, which can cause like vasculitis of any vessel that they go into. They can cause glomerulonephritis if they're in the kidney. They can cause Roth spots, splinter hemorrhages, and the Osler's nodes. And then you can also just get infective emboli. So like I said, where the little bits of the vegetation break off, and they can cause an abscess in kind of any organ that they go into. So the brain, the kidney, any organ really. And they can be life-threatening. So if you have an abscess in the brain, it's obviously quite a serious diagnosis. And Janeway's lesions as well are also an example.
So just to say, Nicole, you're absolutely right. And you know, sometimes so you've got a patient who has an acute presentation with acute vascular event, wherever that is, whether that's in the cerebral kind of stroke, whether it's an acute myocardial infarction, because the vegetation can embolize into the coronaries and cause an MI. Also, you can get a renal infarct, you can get a liver infarct, ischemic bowel as well, and an acute ischemic limb. So if you come across any of these type of presentations with fever, always think about endocarditis.
Kind of when you're investigating for infective endocarditis, so you've got this patient who's got a fever and maybe has one of the risk factors that we talked about. You've got your standard tests, so bloods to look for infection, ECG, chest X-ray, and urinalysis to look for microscopic hematuria in case they do have glomerulonephritis. But the kind of two main things that you really need are blood cultures to look for the bacteria in the blood. So you need to get 3 sets of cultures taken from 3 different sites in the body, and they need to be taken 1 hour apart. And you had to take them before you give antibiotics, because antibiotics might treat the infection, and therefore you're not going to pick up the bacteria in the bloodstream. So that's really important. And then the second thing that you really need is an echo to look for actual vegetation on the heart. And so a transthoracic echo, so that's an echo that's kind of through your skin, through your chest, is recommended in all patients. And so I've just got a little diagram to kind of show you how you'd go through the investigation. So everyone gets a transthoracic echo, but it can be quite difficult to visualize vegetation with a prosthetic valve. So an esophageal echo might be required. So if you have an echo that is non-diagnostic, you also might want to go for a transesophageal echo, so it literally goes into the esophagus, near the heart. And even if it's negative, if you still have quite a high suspicion of infective endocarditis, then you might go on to do a transesophageal echo to kind of better visualize the heart and see if there's any vegetations you've missed. And then even if you then do an esophageal echo and it's negative, but you're still pretty sure that it sounds like infective endocarditis, you should then repeat an echo within 5 to 7 days to see if any vegetation develop in that time. And nowadays, there's also lots of other ways that you can look for vegetations if you can't see them on echo. So you can do like a CT of the heart, or you can do PET scans as well to try and visualize those vegetations. So if you've got your blood cultures, you're hopefully going to see if you can find any bacteria. So the bacteria that you get in infective endocarditis kind of varies according to what type of valve you've got in. So people with prosthetic valves tend to have more coagulase negative staph, enterococci, and gram-negative bacilli. And they can also have Staph aureus, and that tends to be kind of earlier after the valve was put in that people would have Staph aureus. If you have a native valve, you're more likely to get a viridans group streptococci or enterococci or staphylococci. Then if you're an IV drug user with a native valve, sorry, you're more likely to, sorry, I just need some water. You are more likely to get kind of Staph aureus because that's kind of on your skin, so it can get into your bloodstream through the needle. You might get streptococci, gram-negative bacilli, or you might just get a polymicrobial infective endocarditis. So there's just loads of different bugs in the blood. And another thing to note is it can also be caused by fungal organisms as well. So the treatment of endocarditis is guided by criteria. It's called modified Duke's criteria, which I'm sure you've heard of before. Basically, you score people on kind of these different criteria, which we'll go through in a second. And if they have either possible infective endocarditis or definite infective endocarditis, then you treat them with antibiotics. So there's two pathological criteria, which if that box is ticked, if they have that, they definitely have infective endocarditis, there's no question. And so one of them is if you've histologically kind of examined a vegetation and you found these microorganisms, then that confirms an infective endocarditis. Or if you've got a vegetation or intracardiac abscess which has been confirmed by histological examination and it shows endocarditis. So it's either like you see the microorganisms on histology, or you on your histology see that it's an endocarditis. And obviously quite difficult to remember all the criteria. So the MD Calc app has a really good way of measuring a patient's criteria score. So these are the criteria. So you've got your major criteria, so positive blood cultures. So if you've got 2 positive with a typical infective endocarditis bacteria, or persistently positive blood cultures, or if you have evidence of endocardial involvement on echo. These are the 2 kind of major criteria. So that's why it's really important that you get that echo and you get your blood cultures in your investigation. And then you've got minor criteria, which aren't quite as strong for diagnosing infective endocarditis. So that could be the predisposing factors that we talked about. Could be having a fever, having the vascular features, so like Janeways, lesions, or arterial emboli, or it could be immunological phenomenon like the Osler's nodes, or you could have kind of microbiological evidence, so a bacteremia, but it doesn't actually meet the major criteria, or you could have an echo consistent with endocarditis, but again, it doesn't meet the criteria on the and so in order to be able to be diagnosed with infective endocarditis, you either need one of those pathological criteria we talked about before, or you need to have both the major criteria, or you can have one of the major and 3 minor, or you can have 5 minor. So it's quite difficult to remember, so it's definitely worth downloading MD Calc. And so infective endocarditis, it's an infection, so the main way that we treat that is with antibiotics. So like I said, you suspect infective endocarditis, so you take blood cultures before you give them. And then obviously, as I said earlier, it takes a few days for blood cultures to come back. So whilst you're waiting for them to come back, you just start broad spectrum antibiotics. And this would probably be according to local guidelines, but on the Manchester microguide app, they had these ones for a native valve and a prosthetic valve. And obviously it's different antibiotics because different bacteria tend to cause infection in these different types of valve. So then you get your blood culture results back. And I mean, usually in real life, you would just discuss with micro and see what they recommended for whatever's grown in the blood cultures. And so if it's a native valve endocarditis, they're usually treated for about 2 to 6 weeks. And if it's a prosthetic valve, they're usually treated for 4 to 6 weeks. And you repeat cultures at 1 and 2 weeks to make sure that you're clearing that bacteria away, treating the infection. And you also want to get a repeat echo at the end of treatment. And then you also want to get one another in the first year following discharge or following the treatment, to make sure that you've cleared that infection away, and also to figure out what the patient's new baseline is. So if they come in again and you're suspecting endocarditis and you get an echo, you can say, oh, it's worse than last time, or you can say, oh, actually, that's their baseline. We're happy with that. And some patients, unfortunately, end up needing kind of surgical management, which is obviously a bit more of an undertaking. And around 50% of patients end up requiring surgical intervention. And the aim of that usually is either to remove all the infected tissue or to replace or repair the damaged valves because they're not working properly. And I think preferably you'd like to treat people kind of once the infection's cleared, once they're a bit better. So some people have elective intervention, which is about after 1 or 2 weeks of antibiotics. But some people, if they're really unwell, will need early surgical intervention. So that will be within 7 days after they've been diagnosed. And these are the patients who need that are patients who present with decompensated heart failure. So they're really quite unwell. Or like you're giving the patient antibiotics, but their infection's just uncontrolled and they're still really unwell. And it also might be to prevent embolisms as well. So you don't want the patient to get any further. So you just want to get rid of it. So yeah, you want to get kind of cardiothoracics and the MDT involved early.
Yeah, absolutely. Nicole, try to just make a comment just very quickly. Yeah. So you're absolutely right. And what it is that there are risks with surgery. And the main concern with early surgery is that the prosthesis can get infected. So that's why ideally, if you speak to surgeons, they would prefer to wait until the antibiotics completely rendered the vegetation sterile before they go in. But the main reasons to go for an early approach is if you've got not just that you presented with heart failure, but that you've got uncontrolled heart failure, still kind of persistent heart failure, and that's usually because they've got severe, for example, in your case, aortic regurgitation, for example. So you just can't get them out of heart failure. And then the other one is if you've got a very, very large vegetation. So the size of the vegetation is important because the larger it is, then there's a huge risk of a lethal embolism. And that's, so those are the main sort of considerations.
And then obviously patients will need to be followed up. So it's quite useful when you're like writing discharge summaries and stuff on the board, to know why these patients are having follow-up and what they usually have, so that you can make sure that that's sorted. So these patients should be followed up by the infective endocarditis MDT or a heart valve specialist. And part of the follow-up would be, as I said, an echo within the first year afterwards. And also it's recommended to take bloods and blood cultures at the initial follow-up appointment to check that infection has definitely cleared and that the patient is better. So that's everything. So I don't know if anyone has any questions, but thank you for listening.